Good afternoon, everyone. It's a pleasure to have Dr. Ron Brookmeyer today. This is our November Method Seminar, and I think a few of us might be still trickling in. Feel free to have some fruits and unhealthy. So today we're very fortunate to have Dr. Ron Brookmeyer, professor in the Department of Biostatistics at UCLA. He's going to be talking about tracking the HIV/AIDS epidemic, issues, challenges, and future directions. So I'm very excited to hear this talk, and I think it's a very relevant topic for many of us. So
okay.
welcome.
All right, sure. Well, thank you very much for the invitation to speak today. And it's a pleasure to be associated with CHIPTS and get to know the team here. So I've been working on HIV/AIDS for many years, and it's interesting that some key issues that we face 3 decades into this epidemic about tracking and monitoring, and a lot of those key issues are still on the table and have not been resolved. I had last September, this past September, traveled with Roger Dietls to China, where we've been giving a series of workshops. And at the Chinese Center for Disease Control, where the National AIDS Program, directed by Zhenyu Wu, who has an association here at UCLA, and they asked us to do a series of workshops, and part of it had to do with understanding and tracking what was actually going on in China. And let me see if I get this right. So one of the issues were some conundrums and some paradoxes in the Chinese data. And some of the issues was this is the HIV/AIDS mortality nationally rates in China. And they were going up. And this is not what they wanted to see, especially with expanded use of antiretrovirals. Why was it going up? What explains these paradoxes? Is this real or is this an artifact? So this is not the first time that there have been conundrums and paradoxes in national government level and world statistics. For example, UNAIDS a few years ago abruptly revised their estimates of worldwide prevalence down 6 million. At the same time, they abruptly changed their estimates of HIV incidence down 42% per year. So how do we explain, what do we make of these issues and these changes? And so that's what I want to talk about today. What I want to talk about is how some basic issues about how to understanding trends in national and world statistics. What are the challenges in interpreting these trends, and what are some measurement issues that go into some of the key indicators and some current and future directions for tracking and monitoring the epidemic at national and global levels. So some vocabulary to start. Here are some indicators which we routinely use to measure and track an epidemic. So one is HIV prevalence, of course, which means the proportion of persons alive who are HIV infected. HIV incidence rate would represent the percent of persons per year who are becoming infected, or the number of people per year who are becoming HIV infected. The HIV/AIDS mortality rate represents the number of deaths among persons with HIV infection out of the total population per year. So how do we interpret some of these trends? So let me start with mortality trends among HIV-infected persons. Now at this point, I'm going to be assuming we have complete reporting of deaths, and that's an important measurement issue. Do we have complete reporting? But let's assume for the moment we have perfect measurement. What is the interpretation of an increasing number of HIV-related deaths? It's hard to tell. Is this good news or is this bad news that the deaths are going up? Well, actually, this series of deaths was underlying it was this rate of new infections. So there is a delay, the incubation period, between when you're newly infected to when you surface as either symptomatic or as AIDS. Symptomatic with AIDS or as a death. So in this case, we're seeing a waning epidemic, even though the deaths continue to increase, because this bolus of cases are now moving forward here. So in interpreting trends, it's possible that HIV mortality can be increasing, even though the current HIV incidence rates are decreasing. And that's because persons who were infected years ago are the ones that are now dying. Mortality trends do not reflect recent HIV incidence trends. And in fact, you could have had the same picture, exactly the same picture, of underlying HIV incidence and deaths, but you could have had a sharp rise in HIV incidence in the past year, and none of that would have been seen at all in the underlying deaths. In fact, even if there was treatment, active antiretrovirals going on, you might still see increasing deaths, but you wouldn't be able to know it because there's no counterfactual to compare it to. There could have been antiretrovirals improving survival, but still the deaths are increasing, partly because of the large number of persons who were infected years ago. So mortality and HIV-related deaths can continue to increase, even though ART is expanding and is effective in preventing some deaths. So in addition to the HIV mortality rate, which is number of HIV deaths during a year, HIV-related deaths divided by population size, there is another indicator that can be used, which is the case fatality rate. And this represents the deaths during the year among HIV cases over the number of alive HIV cases at the beginning of the year. So the difference between these two, this is the denominators are different. So this is out of population size, and this is out of the number of HIV-related HIV cases that we have alive at the beginning of the year, what proportion of them actually die during the coming year. And these can give you different pictures. So let's go back to the Chinese data, which showed an increasing HIV/AIDS mortality. But when we look at the case fatality rate, we have a different picture. So the
previous picture I was just curious what those four groups are.
Those are age-related. Age-related.
So 0 to 14.
So here, with when they calculated case fatality rates, you see a declining case fatality rate with year, and this was antiretroviral expansion, representing expansion. So case fatality and mortality rates can go in different directions. They've got different denominators. And and can, yes, and they can move in opposite directions, and that's what was going on in the Chinese data. The case fatality rate, HIV case fatality rate, was going down because of better survival, increased treatment, more effective treatment, wider access. But the mortality rates were going up, and that was because of high incidence in the past, and those cases were now moving through, even though there have been recent improvement in survival. So these two, again, case fatality and mortality rates have different denominators, and that's where some of the conundrum here in sorting this out was going on. One organizing principle for understanding this is a little equation, which is if you think of the probability of being an HIV death, first you have to be an HIV case, say a case in an advanced stage of disease, and then given you have HIV and you're in an advanced stage of disease, the probability of dying during that year. This is getting at the case fatality rate, which could be going down, but the prevalence rate could be increasing due to past high rates of incidence in the past. And because of these opposite directions, the mortality rate can be going up or down. If it was just that easy, turned out what we just talked about was when you have complete reporting of deaths, of HIV deaths. But actually, that is the measurement issue here is critical. And in fact, there was a major further complication in the Chinese data, which is that the deaths, measurement, only deaths which with a prior HIV test were counted. Well, obviously, if you're counting HIV-related deaths, you have to have an HIV test to begin with. Otherwise, you don't know it's an HIV-related test, HIV-related death. So that persons who were had a test for HIV, all of them are being followed up for death in the national Chinese data, and most of them are counted, but some of them could have been missed. More importantly, are people who did not have a prior HIV test, and some of them are missed completely. If they are diagnosed with symptomatic disease and make it to a hospital, some of them do not get an HIV test. They would be missed completely as HIV-related deaths, and those with an HIV test, some of them possibly, even those may not be actively followed for deaths. So that there's considerable underreporting, and you can see in this schematic that the major driver of counting deaths has to do with whether or not they were screening for HIV. So with mortality, if only deaths with prior HIV tests are being reported, so counting of deaths requires an HIV test. Then increases in testing can cause increases in the reported mortality rate. So even though so imagine a situation where the true mortality rate is actually constant. In that scenario, then even if there's an increase in HIV testing and screening, which is good news, we're going to start to be counting more. And so that's another explanation in the Chinese data for why there was increasing HIV mortality. So what about trends in prevalence? Sure.
Have there been, has there been work on like simulation type models to see under different scenarios what, how that would translate into, like suppose, as you said, suppose the death rate is constant, and how it would look under different scenarios for reporting or for increasing testing and so forth.
Yeah. I haven't seen detailed simulations of this. But incorporating the extent of screening into this and making adjustment would be a natural kind of extension for how to combine the expansion of HIV testing into this and do an adjustment. HIV prevalence trends.
So Ron, just a quick question on the case fatality and HIV mortality example you used. Are you taking into account of the actual cause of death in all these HIV-related deaths?
So that's a good question. In what I showed you, it was an HIV death. And generally that's what's done. I think the data on cause of death and calling it an HIV, the cause underlying was HIV, it gets a little softer, and sometimes the cause is not reported. So what I showed you was deaths among HIV without regard to the cause of death. Trends in prevalence. So prevalence is proportion of people alive who are HIV infected. It's the easiest data to get. How do we interpret trends in HIV prevalence? Well, prevalence is new infections coming in, people living with HIV infections, and then there are then there are deaths. So prevalence may be increasing or decreasing depending upon whether HIV deaths are increasing, are greater or less than the number of new infections. So input and output. Prevalence can be constant even though incidence and deaths are rising. So even though this is increasing and this is increasing, that would be masked, and you wouldn't see that. You'd only see a constant HIV prevalence rate. Prevalence can be increasing, HIV, because survival is increasing, which could be good news. So increasing prevalence could be good news. On the other hand, prevalence can also be increasing because HIV incidence, the input, is increasing. So it's hard to sort out by tracking prevalence by itself. Is that good news or is that bad news? So when we have multiple indicators, incidence, mortality, and prevalence, you can get different stories. And they can all go in different directions in terms of assessing what's going on with the epidemic. So for example, here's a scenario. This was one where incidence is decreasing, mortality is increasing, and prevalence is decreasing. One story that goes with those indicators is one of a waning epidemic, where the incidence has been dropping, and prevalence is dropping as more people, those people who were infected years ago, are dying. A waning epidemic. On the other hand, you could have a very sharp, abrupt, very recent increase in HIV incidence and still have these directions for mortality and prevalence, and the epidemic could be growing rapidly in new groups of individuals. You could have both increasing incidence and increasing mortality, but in prevalence, if you're tracking prevalence, can remain absolutely constant. Whoops. Oh, I shouldn't touch the screen, right? Wow, that was really cool. Wow. I'm in a state-of-the-art facility here. Is that right?
Yeah, you can draw on there if you like.
Is that right?
So you can use one of those markers at the bottom, lift one up,
Like this?
Yes.
and then put a smiley face or whatever.
Are you?
Yeah, you can circle on it.
I actually did this in one of my classes. It was a screen, but it was a real screen, and I picked up and I marked up the screen permanently. This is not a trick. This is still this is okay?
It's okay.
Are you sure?
Yes.
It's so.
I've been covering up your mistake for years.
Wow.
This is smart board.
Wow, that's wonderful.
You can erase it with an eraser down there too.
Are you serious? Wow. Wow. And then you can have, it's smart.
So
That's really
yeah.
smart.
So it's device specific. So if the marker is on,
Okay.
using the marker. So when you want to erase, you got to put the marker down.
Got it. All right. Okay. So, you can see here, you can have both increasing, but yet the prevalence is constant. And then the good news, a good news scenario would be HIV incidence is decreasing, mortality is decreasing, but prevalence is potentially increasing only because of the longer survival. So it's complicated. And this is a picture of US data, which shows you the complexity in tracking all of these indicators. Here, for example, in this case, an indicator here, the top curve, were AIDS diagnoses. And you can see here the sharp increase in AIDS diagnoses. Hidden below there is the calendar time, and partly this expansion right in here actually had to do with a change in the case definition. And that accelerated the diagnosis of cases, because back then in 1993 they expanded the case definition. And then you can see a drop over here, and that drop was because they had expanded the case definition, and then there was a deficit of cases in the next calendar period because they had been accelerated forward. And so changes in case definition make these anomalies. Over here, this was deaths, HIV deaths, and you can see here the increase going on, and then this does reflect the beginning of antiretrovirals and the expansion of antiretrovirals. And you can see prevalence increasing, and the increasing prevalence is going on for different reasons early on, both because of the rate of new infections that were happening, and then it continued to increase partly because of survival and increasing survival. And all of this is happening, and we know that actually HIV incidence in the United States peaked back here in the mid to late 1980s. So we have all of this complexities going on.
Might even add that the new case definition in '93 included people who weren't as far along, so that might have also been reflected in longer survival afterwards.
Yeah, yeah. So trends in incidence, prevalence, and mortality can be difficult to interpret. They can go in opposite directions. And you got to look at all of the indicators to tell the story. And even if we knew all the indicators perfectly, there are important challenges in measuring these indicators, which makes interpretation even more difficult. So all of the things I was talking about was even if we could measure these perfectly, but in practice we can't.
So in the previous graph, when they reclassified the definition of, did they go back and retroactively do that? So all those other lines based on pre?
Yeah, it's a little tough to do that because they're expanding the, to do that back allocation, you have to know what would have happened to people if there hadn't been any intervention, or you'd have to know. So it could be done, but it's hard because if it was based on a change in your CD4 count and now you have to be at a different level of CD4 count, they'd have to project when you would have reached that CD4 count to have been classified as HIV. So attempts have been made to do what's called a consistent case definition over time, but it's not perfect. Yeah. Okay, so some measurement issues. So this is Science magazine. India slashes estimates of HIV infected people. And the following year, UNAIDS, and this was that statistic I cited earlier, worldwide, UNAIDS says worldwide HIV prevalence down 6 million. So what's going on here? Well, around that time, they started expanding the number of probability-based, population-based samples of HIV prevalence. And prior to that, they were selected samples. So now we have probably in over 50 countries these demographic and health surveys, for example, which are household-based, probability-based samples of HIV prevalence. And before that, India had actually conducted a national survey, and when they conducted that national survey, they had found that the rates were lower than when they were based on surveys of antenatal clinics.
Ron, are those surveys based on HIV testing of these randomly selected households or of reported diagnosis?
No, they're actually, the demographic and health surveys, they've added in a AIDS component. So they're actually going in and getting a randomly selected household member and testing them and getting the bloods. And so that's turned everything upside down, because now you've got, now I mean, I don't want to leave you with the impression that household surveys are going to be better, necessarily the gold standard, but they may be better. They may certainly be better than some selected populations, particularly antenatal clinics, which are all women and so forth. And in fact, some studies have been done to look at how do these national surveys, where it's not self-report, where they get the bloods, these national surveys in various countries compare to what's been done in the antenatal clinics, pregnant women. And this is the ratio of the HIV prevalence estimated from national surveys versus antenatal clinics. And they're averaging at around 0.8, so that the national surveys are about 20% lower of what you're getting from HIV prevalence than based on antenatal clinics.
For the people that are selected to be tested, what's the rate of refusal? Or is that tracked at all?
It is tracked. It is tracked. And I don't, it was good. It was good, but I don't, that was my recollection. It was good. I don't recall the exact number. I think that reference has gone into it in depth in terms of the,
It's about 90% in the C2 and Malawi, the people who take the HIV test,
Hmm.
after being accepted in the surveys.
yeah, that's pretty good.
That is pretty good.
So this brings to the critical issue in HIV, in all surveys of this sort, is the representativeness of the survey. And it's one thing, its representativeness from households is one thing, but trying especially to get at some of the key populations and marginalized populations, MSM, sex workers, persons who inject drugs, this is a critical question and challenge which is on the table, which is how can we get representative surveys of these groups. And so let me turn now to perhaps our biggest challenge, which is HIV incidence. And an HIV incidence is really the leading edge of the epidemic. And if we can track HIV infections, the occurrence of new infections, that is going to tell us whether our prevention programs are working, and kind of it's the leading edge, what's actually happening with the epidemic. And it's kind of startling that at this point in the epidemic, we still don't have a widely, universally accepted methodology for, and that's cost effective, for getting representative estimates of HIV incidence rates. So let me tell you a couple of the methods that are being used for getting at HIV incidence rates and what the challenges are. So the first is the changes in HIV prevalence method. So the basic idea here is that we take 2 serial cross-sectional HIV prevalence surveys, and from that infer something about the growth of new infections from how HIV prevalence changes. So that would suggest a balancing equation, if you will, that the change in prevalence, well, the change in HIV prevalence, what's going to change it? Well, if there are new infections, but there might be HIV deaths, so you subtract those off. And then there also might be net migration, which adds a whole nother complexity to this. So the estimates of incidence from this balancing equation turn out to be very sensitive to assumptions about deaths and require prohibitively large sample sizes. So we've actually done some work on this and try to, if you can estimate prevalence at 2 points in time, and call p hat 1 the HIV prevalence at the first time point, and p hat 2 the HIV prevalence at the second time point, and the difference, the time difference, say, is delta. So we've come up with an estimating equation for the incidence that accounts for deaths. It's not accounting for net migration, which would be an important extension to this of how to do that. But what it depends upon here is the relative survival of HIV-infected persons compared to the population, the mix of infected and uninfected. So the relative R is the relative survival, and so an R of 0.8, for example, would suggest that the survival of HIV-infected persons surviving the duration of time delta is 80% of what the whole population, the survival of the whole population. So R is calibrating how the survival of HIV infected persons compares over this time period delta. And what was interesting about this equation is it involves only the relative survival, doesn't actually involve the absolute survival rates. So that was a simplification here. So, we did some analyses, implications of what all this means in terms of estimating incidence from changes in prevalence. And this is a graph that shows what kinds of sample sizes you would need in 2 prevalence surveys to accurately estimate incidence. And you need large numbers. And so this is the sample size that you would need to, at 2 points in time, two surveys, to have a coefficient of variation in the incidence rate of 0.2, which means that we don't want to have too much margin of error. And it's assuming a relative survival of 0.8 of HIV infected compared to the mix of infected and uninfected in the population. And a couple of things to note. First, these different curves give you the sample sizes for different underlying incidence rates. And you can see the lower the incidence rate, the bigger the sample size you're going to need to see anything or to get any precision. The second thing you note is that as the baseline prevalence increases, the prevalence at the first time point, the bigger the sample size you need. And that wasn't immediately intuitive to us. Part of the explanation for that is, imagine if P1 is really small, the baseline prevalence at the first time point. Then at the second time point, almost all the prevalence that you see can be attributable to new infections. So whereas if the prevalence is high in the beginning, it's very, and you see prevalence going up, it's hard to distinguish what was a new infection from what was a long-standing infection. So when you start de novo with a new epidemic or very low prevalence, you can then attribute all the increase in prevalence to the new infection, and that's why you don't need as large of a sample size. So here, for example, if the incidence rate is 2% per year, and the baseline prevalence that you start with is 10%, to accurately estimate incidence, you would need over 11,000 people. That's going to be pretty tough to do. If the incidence rate is 1% per year, and the baseline prevalence is 20%, so we're over in this part of the curve, using this methodology, you would need 93,000 individuals at the 2 time points. So it's sobering. It's also sobering that it is very sensitive to R, the assumption about deaths and mortality. And this shows the sensitivity to misspecification of the relative survival rate. And it's actually showing for different, these curves represent different levels of bias, and I'm showing it all for negative bias in the relative survival. But it's a similar picture for a positive bias. But basically, if you underestimate the survival of HIV-infected people, if they're actually living longer than you think they are, that's what these curves are showing. This shows the bias in the incidence if you try to estimate incidence by changes in prevalence. So for example, if the bias of the relative survival is negative, so you think people are, you're underestimating survival among the HIV infected, your incidence is going to be overestimated. And the reason is because any increasing prevalence that you see is going to be falsely attributed to new infections rather than longer survival. So if you see increasing prevalence, it's either due to more new infections or increasing survival. And if you've miscalculated the survival, you're going to be, and the survival is actually longer than you think it is, you're going to be attributing the increasing prevalence to higher incidence. And so you'd be overestimating incidence. And how big is this? It's huge. So let me give you an example. With a baseline prevalence of 20%, many situations in Africa, for example, if the true relative survival is 0.9, but you make a little mistake, and it's 0.8, then your incidence would be overestimated by 2.5% per year. So if the true incidence rate is 1% per year, that small little error in your relative survival is going to translate to, you're going to be estimating instead of 1% per year, 3.5% per year. So you'd be off by a factor of more than 3. So incidence is sensitive to the mortality assumption when you base it on changes in prevalence. It's very sensitive to it. So if you underestimate the survival of the HIV-infected population, you'll be overestimating incidence. If you overestimate it, you'll be underestimating incidence. And it was these changes and this sensitivity is what changed the had such an impact on the UN AIDS numbers of HIV incidence. So back in the beginning, when I said they dropped worldwide HIV incidence by several million, and they dropped it from UNAIDS from 4.1 million to 2.5 million, it turns out the reason that happened was because they changed one of their assumptions in their models. They were basing it on a change in prevalence methodology, tracking prevalence and trying to infer from changes in prevalence what happens to incidence. And they, partly because of expanded antiretrovirals, they changed the assumption from 9 years to 11 years as the overall survival experience of an HIV-infected person. And that change is what changed those estimates. So, so is this a real signal, or is it just due to a change in the underlying methodology, which is driving these change in these numbers? Okay, so another method to estimate incidence is the cohort approach, which is the one we know. This is how you classically estimate an incidence rate or a hazard. You take the incident infections divided by person time. And there are issues, of course, with this. Is it representative? Assembling and following a cohort is difficult. The counseling itself that you offer may reduce the underlying HIV incidence rate, which is good, but therefore then the cohort itself is not going to be representative of the more general population. Incidence is changing over the course of follow-up time, and most importantly, you have selection bias, which is who returns for follow-up. And that is not necessarily representative of the more general population. So the third approach, and the one that we've been currently working on and continue to work on, is a cross-sectional biomarker approach for estimating incidence. So the basic idea of this approach is we're not going to do cohorts, okay? We're not going to do longitudinal follow-up. We're going to try to weasel out of this. And what we're going to do is we're going to give people blood tests at one point in time and get some sort of biomarker and see if we could distinguish what was a new infection from a long-standing chronic infection. And so basically it's a snapshot at one point in time and from a survey and see if we can infer something about incidence from that. But to do that, you need a biomarker, and the biomarker has to be able to identify who is recently infected. So you'll collect biomarkers of recent infection, and it's like a snapshot. So it's not, and let me emphasize, you need a good cross-sectional sample. So we'll come back to that. But you need to have a representative sample. We have not gotten out of that issue. So, so here is, what do I mean by a biomarker? This is a trajectory of what happens. Here is the rise in antibodies after a schematic with time since infection. And here might be a biomarker which rises after the standard HIV antibody levels rise. So if you're in this window where you're positive on blue but still negative on yellow, that captures you in a window of time. And that's the idea. So for example, some of the early assays of this system, it was based on an antibody assay, the blue curve, and something called a BED assay, which stands for different subtypes of HIV. And basically it's a detuned approach, and it's one of the few times where you actually want an assay that's less sensitive, that surfaces positive after this one to capture people in that early period. So I've never seen where you actually want a worse assay, but this was one of the cases where you actually want it. And this window is random. It is not a fixed, but it varies in the population. So it's actually a random quantity. So the biomarker approach basically says, okay, we're going to do a cross-sectional sample, and it turns out that the incidence estimator from that one survey to identify the number of people in that window period, positive on blue, negative on yellow. And the estimator is the number of people who are in that window period, positive on blue, negative on yellow, over the number of people who are HIV uninfected in your sample. So there you're getting your incidence rate. And you divide by the mean duration. You need to know how long that window period is on average. So you need to know that. So that has to be brought into the problem. So, so mu here represents the mean duration of persons who are, the mean duration of that window period in a typical person. Good news, no follow-up is needed. Bad news is that you need to know that window period for this methodology to work. So, so we got an R01 from NIAID to actually calibrate this, and it was with some colleagues, Sue Eshelman at Johns Hopkins and Oliver Landecker at NIAID, and what we did was put together a repository of samples, and these were U.S. samples, clade B, from different studies. A vaccine preparedness study, which was the HivNet 001, a multi-center AIDS cohort study we got samples from, ALIVE, which is a study of intravenous drug users, and a clinic of AIDS patients. And what was special about this cohort, these cohorts, was we knew when people were infected, at least within a window of time between the last positive and the first positive and the last negative. So it was interval censored data, but the important point is that we had an interval. And we looked at a variety of different biomarkers for recent infection, including an avidity assay, the new lag assay, a viral load, and a CD4 count. And one of the things we were very concerned about is the cost of all these assays. Viral load is not cheap, particularly when you're going to be doing it on thousands and thousands of people. And if you have CD4, there are logistic issues in your algorithm as one of your biomarkers. They have to be done first because it has to be done on whole blood, and there are some issues, logistic issues with that. The viral load is about 10 times as expensive as the BED, 5 times as expensive as what's called an avidity assay. And so we were interested in developing cost-effective, logistically feasible approaches to use these biomarkers. And that led us to these classifications based on these biomarkers that are done sequentially. So here, for example, is an algorithm that classifies people into that window period, and it's based on CD4 count, BED. But the only people who move to the next biomarker need to be biomarker to have another assay, or those who meet the first criteria. So the important point here is that these assays are done sequentially, and if you fail an earlier criteria, we don't need to test you with the other biomarkers. And that is where there's considerable cost savings in the approach. So, so for example, this is a 4-biomarker approach, and those people classified in the window are those who meet each of these criteria. And again, if they fail any of the criteria, we stop, and we don't test them with any other assays. This is a 3-biomarker algorithm we had for putting people in that window period of early infection. And the average length of the window periods is about 150 or 100 days. So we are capturing people in the period of recent infection. And this shows you the curve of how long people, it's a survival curve, for how long people stay in that window period of early infection using our 4-biomarker algorithm and our 3-biomarker algorithm. And you can see this one is shown with the early work was just done with one biomarker called BED, and that one by itself does not do very well at all. Lots of people are falsely classified as a new infection, even though they've been infected for 6 or 7 years or so. the cost of this. So we looked at the cost effectiveness of this, and here I'm comparing it to testing all samples with all 4 biomarkers. So here we're doing these classifications where we have 4 biomarkers, but not everyone is being tested with all 4 biomarkers. It's done sequentially, and some of them don't need to be tested with all biomarkers. If you tested with all 4 biomarkers, turned out this one is half the price. And then we developed a 3 biomarker assay approach, and that's 10% of the price of testing everyone with all. And the reason is because we're not testing everyone with viral load, and that's where there's considerable savings. And most recently, we developed a 2 biomarker assay with one called lag and avidity, and that's also fairly inexpensive. There was a subtle issue here that the window periods itself, the mean window periods itself, vary, so we have to make some adjustment because the bigger the window period is, you're capturing more people, it'll be more precise. So we actually did an adjusted relative cost, and here they're adjusted to this 4 biomarker approach, and you can still see considerable savings in terms of sample sizes and costs that you need, and this accounts for the cost of the various assays. So how well does it work? So we did an evaluation study, and what we did was we got some cohorts, got some collaborators, got some cohorts, and we measured incidence in the traditional way, cohort study, right? And then we, at last follow-up, at the end of the cohort, we did a cross-sectional sample of those people who were still in the study. So we were trying to negate out that issue about, people dropping out. So the people who stayed in the cohort and contributed to the cohort study were also the same people who contributed to the cross-sectional sample. So that was the best way we can think of to do a head-to-head comparison, which is, does a cohort traditional person year analysis match up with what we're doing in a single cross-sectional sample? So we had 3 cohorts here, an HIV preparedness vaccine study, included MSM, IDUs, high-risk women. That was done in the late 90s, but we had the samples, so we were able to test them. A sero-incidence study, the HPTN 064, high-risk women, and the brother study, US Black MSM. So these were cohorts, and then I'm going to show you the cohort incidence rate, first on person years analysis, and the cross-sectional estimates. And these are based on our 4 assay, and we're doing pretty good. So confidence intervals are wide, and I don't want to, these confidence intervals, by the way, account for uncertainty in mu. Mu is that mean window, and that there is uncertainty. So getting more precision on how long that average duration that people stay in the window period isn't important. But we were heartened by some of these results. Okay, so some current and future directions. First, what everyone wants to know is the incidence going up or down? It's one thing to measure incidence, but we'd like to track incidence. We'd like to track changes. One good thing about the biomarker approach is if you look at the estimator at 2 different points in time, so it's the number in the window divided by the number negative in your cross-sectional sample at one point in time divided by the other point in time, you see the mu, if mu is constant, drops out. So actually, you don't actually need to know mu if the assumption of that mean window is stable. So that's a good thing for estimating a rate ratio or the change in incidence over time. Other ongoing work, statistical methods, and this is with Jacob Konikoff, who is a Ph.D. student who's now at Johns Hopkins of mine, and Rob Weiss, who's over there, and developing a Bayesian approach and and putting it in the framework of continuous data, because what I had shown you was we were discretizing and having cutoffs and allocating. So that's another exciting approach. I showed you data for subtype B. We want to see other subtypes because there are other subtypes in the world. And so the current work we're doing is now putting a repository together of subtype C, which is big in sub-Saharan Africa. So that is where, and there's evidence that some of these biomarkers may well perform differently with different subtypes. So that's an issue. And representativeness. You know, I can say you have a cross-sectional sample, but is it representative? And that I think is really, and the implementation of this is where I think a lot of the action needs to go to. I mean, I've seen a lot of these implementation of these methods, but they're using sampling like respondent-driven sampling and venue-based, and which ones work better? We all know the issues with these, but these methods do not negate all the usual concerns that we have about sampling. And are we getting representative sampling, or is there a skewed sample that we've got? And that really needs, I think, really to implement this, and that those issues of representativeness do not go away. So I'll just summarize a couple of points. First is that indicator trends that we've talked about can be difficult to interpret. And if you're looking at prevalence, incidence, and mortality, you got to look at all of them. You got to look at case fatality rates. You got to look at survival rates, because any one of those is not telling the whole story. Multiple indicators are needed to understand and track trends. You got to think about the underlying data, the measurement issues. Are all the deaths, for example, being counted? The representativeness of the underlying surveys, whether they're based on prevalence or whether it's an incidence survey. And I think some of these new biomarkers using cross-sectional methods, serial cross-sectional studies, is a promising direction for assessing current HIV incidence trends. So, stop.